safe or appropriate to deliver medical care. So how is it now good for your trainees to stay in such an environment? I know in the ACIGME they give them 6 months to correct it or to move their trainees outside the institution. So we really need to be clear about it in here. The financial support, of course, for administrative and educational and clinical resources. Now, what is acceptable? I.e., if someone from the clinical, educational affairs in any hospital goes back to the Saudi Commission and say how many millions or billions even to put in the training to be acceptable. What do I need? Okay, so this is your own judgment based on your understanding of the standards. So this is where you need really to dig into them and understand them and plan your training based on that. Now, it has to be reviewed periodically, and this is very important. Trouble is, who's the timekeeper? Like sometimes we get accreditation, but then 3 years later, the due date for a review, nobody shows up, and we continue. That's why it is in every accreditation rules, whether the ACGME or the Canadian, the Royal College, they say there has to be a periodic evaluation. So you really have to instate it in your institution. It's not just a state of readiness in case somebody comes to accredit you again, but I think it's very important for your processes itself to stay alive. The training sites, whether it's your own hospital or somebody that you collaborate with, there has to be adequate clinical services. I know in the Saudi Commission they say each institution have 150 beds. Now, with the need that we have to move to 4,000 trainees, I'm not sure about the numbers. I will at least put a proxy where beds can be also accommodated by other skills. I.e., if I have a simulation center, how much beds will that convey to add to this number? God knows, but we really have to understand that. And us as trainers, we really have to make sure that we are delivering the standards regardless of the number of the beds. Okay? Yes, there are some minimums, but we shouldn't really stop there. We should really move and train. Accredited by local or international body, as I mentioned, supervision of the trainees, this is very, very important, especially if they are training somewhere else. Believe it or not, even big centers, they have issues with that, because some of our residents or fellows, we send them to go train in another hospital, a twin hospital, okay? But they feel probably from the Saudi Commission local committee that X have to go to Y hospital. But when they go there, God knows, theoretically the program director, they should take care of them. But our program director has to be really in charge of their supervision, to be honest, to make sure that they are there to do their task that they were sent for. Now, to foster intra-professional relationship, this is within the institution. The institution itself has to be based on teamwork building and quality improvement and safety. So be careful when you send your residents to community hospitals. They really have to keep the same quality measures that you taught them in your hospital, rather than go there and learn the bad, behaviors and come back. Also to be accurate and complete with medical records. Now, medical records are moving towards the electronic ones. I'm sure every hospital in the Saudi Arabia now is negotiating with a company to buy a software in order to start. And they will start from level 1 and go all the way to level 7. In King Faisal now we are at level 7. Everything now is and it's really putting a burden on our trainees. Consultants, they go in the morning and they tell them, do this, do this, do that. On the weekends, when there is no resident in our service, we struggle with the computer in order to put an order, to extract an information. Okay? Now, that means that your trainees gonna be consumed with something else. You really have to put that in the curriculum. You have really to understand what are they doing during the day. Of course, with increasing the numbers, you will have some room, but that will entail that their clinical experience is less than before. Surgeons in the past, they used to cut a lot. Okay, when they finish their 4 years or 5 years program, they are the best surgeons, not the best physicians, but they are the best surgeons. Nowadays, our surgeons are more academics, more leaders, more this, more that, and they lack some of the issues. I was trained in a country that I heard this center is a cutting one, this one is an academic one. So you better go for the cutting because you're not staying in this country. Okay. Now the requirements again, the governing body, and you talked about it earlier, and that's very, very important, where you have the leadership involved in the application of these standards. The designated institutional official for that is usually the executive director or the director of the academic affairs or the postgraduate center. Now, how they function, they have to collaborate with training committees, with the accrediting body, have the authority and responsibility to oversight the administration of the accredited programs, and ensures the compliance with the institutional and program requirements. Now, the quality of the work, the commitment, the support from these departments is really variable. Some hospitals are really, really involved. I claim that King Faisal is very, very involved from the beginning, because our training department was founded in the early 80s. So we really have it as a culture. It was instated in the hospital from the get-go. Like, we did not become an academic or a training afterwards. No, we started with that. Not every hospital will have the same experience. So for you now to be able to get into this, I think you have to reformat the leadership. And I think the first lecture by Dr. Aribi about the governance have really gave a lot of insight in this. And administrators, when they get this job, they shouldn't really think of it as a pure admin. They really have to think of themselves as trainers. They have to see what is the end of this department. It's a practicing physician. So the quality of that practicing physician will depend on your quality for commitment and support for these programs. Now, a reality check in Saudi Arabia, of course, the academic affairs or postgrad are the one taking care of that. So this goes back to the higher administration, the CEOs and their likes. They really have to make sure that the leader in that place is actually qualified to lead such a process. Saudi Commission recently has empowered the position of the academic affairs. In the past, we used to struggle to get information from our program directors with even results of exams. The last 4 or 5 years, there was a move from the Saudi Commission to move all the communications through the academic affairs in order to empower them to be able to do their role. Some issues relative to role program directors are still vague. Program directors sometimes are confused whether they are under the umbrella of the Saudi Commission or under the umbrella of the the academic affairs in the institution. This is very important, that institutions have to sit down with their program directors and explain to them that the role is one. And whether they put this hat or that hat, the same amount of information has to be available for both ends. And they should be really a good channel between the Saudi Commission and the institutions. And it is again the responsibility of the official in that department to make sure that this happens. Again, with the requirements to develop and review programs from the educational committee. Now, this educational committee is the most important structure, to be honest, because that's where you get all the program directors headed by the head of the academic affairs or his delegate, in order to make sure that all the standards of accreditation and others are applied in your institution. Okay, that's why it has to be shared by a senior officer in order to give it really the weight that it deserves. It may have subcommittees, meet regularly, keep minutes, and composition. Program directors has to be in it. Healthcare admin has to be in it in order to have quick decisions rather than to wait till you communicate with others. Now, elected residents, we struggled with that ourselves because we have 100 residents in internal medicine, and we have 35 in general surgery, and we have, let's say, 35 in pediatrics. So if we call for an election, who's going to be the member all the time? They're in medicine, because they don't know the others. And they, unfortunately, you can't really create yet one community among those residents, so they will be able to interchange with each other and say, okay, we want so-and-so because of his qualities, regardless of where he comes from. Like we have only five urology residents, but maybe that resident is the best to lead his colleagues in these meetings and represent them. I think we have to empower residents and try to get them to get that role. Members of the committee are very important, especially program directors. You really have to choose good program directors. My colleague next going to be talking about the program directors and their functions, but you really have to have people who are there to add value to this committee. If you are bringing people just to attend or do calls for their residents, or you know, just go to the meetings in the Saudi Commission, then you are not really getting any value. You could send anybody and he will do the role. Members' enthusiasm and involvement is very important. The selection. Some hospitals, they rely on chairman. They say to the chairman, just send us someone to represent you, become the program director in that committee. That's very dangerous, because sometimes chairmen, they have other interests in trainees other than training. They want service. So they send someone who are really going to do that. For us in King Faisal, for example, we have put it in the policies. They nominate, we appoint. And we fight, not a lot, but at the beginning, you know, there was a lot of resistance from some chairmen, because they think they are in control. Okay, you are in control of patient care, but you are not in control of training. We own the training, okay? You are part of it, but we have to ensure that the program director really going to be going by these goals and objectives. Members' benefits, that's another issue here. Some of them, they say, why should we do it? You really have to talk about the benefits on both sides. Some hospitals, they may not have even the real one, the tangible ones, but you have really to work hard on the intangible ones. You have to give them time, you have to give them appreciation, you have to give them awards. You really have to make sure that they are well appreciated in the hospital and looked at as leaders. And they will be happy, by the way, because you cannot really afford them in a monetary way. And the trainees' role, I think it's very important, because some of the trainees are really passive. They think they're there just to stay for 4 years or 5 years or 6 years and take a certificate, go on and then look for a job. No, they really have to be part of this. Luckily now the Saudi Commission is moving towards more involvement of those trainees. It's very difficult to imagine that you will have 5,000 trainees represented by one in a committee or something. But I think this is the start. When you potentiate them and empower them, they will be able to even talk about their own curricula and how is it delivered and how is it done. So the quality of the work of this committee dictates really your position on the national training map. If you are to be known as a good training center, this is the committee that's going to really make the difference. On that line also, the committee, they maintain an appeal mechanism, ensure proper educational environment, intimidation, harassment, abuse. I am 100% sure if I take now an official in the academic affairs and ask them, how many incidents have you encountered? They're probably going to go with 0, maybe 1 or 2, because one angry resident dashed in the door and complained of something. But do we really have a process for it? I once digged into it. I started asking residents from different institutions. This is not a study. I face them and say, are you happy? Everybody's happy by default. But when you really start digging, you will find that they are miserable. They're not happy with the training. They're not happy with their colleagues. They're not happy with their teachers. Then I said, then why are you saying you're happy? He said, because you expect me to say I'm happy. No, you're not. Yeah, they should be happy. Exactly. So now I have to stop the discussion at that point, because I don't have personally any further planning for them. Because if I will open the door, the other 10% down there who are not good, they will just convert themselves into unhappy residents. And they will come up with all kind of complaints about the program and their colleagues. And this is very important. You really have to have a clear point, you know, and how to accept them, and when you accept them, how you're going to funnel them, and go back always to your standards. How is it affecting your training? That's how I'm going to take care of it. And safety again, like luckily they don't travel, so it's fine. Now, again, they ensure adequate supervision to protect patient consultants and trainees. They ensure that programs teach and assist residents' competencies. That's very important. And ensure adequate opportunities for faculty development. This is again one of our issues here. And I received a question in Riyadh, and I reacted in a way, or I answered it. And I want to ask myself now the question in this context and re-answer it. The question was, how can we make our consultants enthusiastic and participant in the training tasks? Because some of them, they refuse. Not they refuse, but they are passively passing the residents. They think they're there to see their patients, take care of them, and that's it. But when you really ask about the enthusiasm of that faculty, his real contribution, the added value to the training, nobody really is interested. When you ask them, they start complaining, either the level of the resident is not fine, or we are not interested, or the hospital is not happy environment for us, or my salary is low and they gave so and so. Now, I think the person who asked me, he asked it in a way that they are refusing to do it, so I just said to him, then you can punish him. I mean, not punishing physically, but punish them by telling them that this is one of their duties. It is in our contract as consultants that we have to train, by the way. But because nobody really is abiding by it, everybody forgot about it. The other thing on the negative part, which is the punishment, you really have to tell them that this is not a choice. Because if you don't train residents, you will not get residents. Then you will have to do your own things. And the CEO should refuse to bring him a specialist or an assistant or somebody to do this work. So he has to do it himself. By the end of the day, either he will relent and train or he will leave. Now, saying this is only applicable in 5-10% luckily. Because most of them, I think, they are willing to train. They are willing to participate. They want to train. Trouble is, they are not appreciated for it. They are not recognized for it. And recognition is not money. You really have, first of all, to find out about their problems. If someone is covering, a dentist was saying, I have 8 sessions a week, okay, and I have half a day administrative, and the other half I have to do my own paperwork in the hospital. How am I going to be able to train and really make a good training and make an impression? We really have to solve their problems in order to make them good teachers. You have to develop them. You have to give them the skills, and that's where the faculty development comes, okay? And you have to help them in every joint of that training process. Like, we sometimes ask our consultants to go and do research, and none of them does it. You know why? Because most of the institutions, they don't give them the resources that they need for it. A consultant is not expected to go and collect the data himself, analyze it himself, write the paper, and do everything in it. But if you give them a coordinator, if you give them the data, if you give them the databases, they're probably going to do it. Again and again, trainers are very, very important aspect of training. So you really have to put them with you in this standards issue. Then they will help you. Now I'm just going to take you over the journey in King Faisal quickly. This is just few things, and I have a goal at the end of it. This is where King Faisal started. We started the clinical thing, I think, in '79, and it was all from the get-go. It was a heart hospital with other disciplines. Then we shifted to oncology, and they brought the big names in the world, like the Bakeys, and a lot of people came to that hospital to do certain things on the instruction of King Faisal, peace be on his soul. But with time, they realized they need trainees. They need people to do the work. So they brought people for 2-3 years, and they asked them to get acceptance, so to go on scholarships, because there wasn't any training programs in the kingdom at that point. But then there wasn't really enough scholarships for everybody. So in '83, they started forming programs. 44 residents and interns were acquired that year. No formal programs at the beginning. Internal medicine and pediatrics were formulated, and they also allowed the AC, FMGs, and flex in order to prepare them for scholarships in the States. In '84, the first Residency Education Committee was formed. '85, 4 major residency programs were made, which is surgery, pediatrics, medicine, and OB/GYN. Then they started putting together the structures, the policies, the formal teaching and training, program directors appointed, and off-site training arranged. That was in '85. '86, the Arab Board accreditation was done of 4 programs. Dentistry, neurosciences followed. In '92, the Saudi Commission was founded at that point, and of course we joined. The number of the programs grew, and the number of trainees exponentially increased. Currently, we have 23 residence programs and 67 fellowship programs, and I think 3 or 4 are on the way of being approved. Extra ones. I'm just going to show you these numbers. I don't want you to remember them, but look at these numbers about the joining graduates from '83 till 2013. Look at the numbers. How are they going up? Then the graduates on the other one here on the right. again numbers, again graduates every year. And we are really splitting them now with whether they are sponsored by King Faisal or they come from sponsored by other institutions. I think the message here is it's becoming complex. Training is not as easy as it used to be. You know, you used to have a small number of programs, small number of trainees. Now it is so complex with the national pressure now to increase the numbers of the trainees. Okay, and we just heard the officials here saying that they're going to acquire 4,000 residents now a year. Now currently I think it's 2,400 or 500. So we're going to jump in 2-3 years, they're going to be 4,000. I don't know how that's going to impact us, but we really have to be ready. And the only way we can stay focused is to keep the standards in front of us all the time. If we cannot meet them, then we have to go back to the Saudi Commission and say we cannot do it. We need more this or that in order to do it. Going back to the standards, this is just to bring them in a context of weaknesses and how can we improve. So the administrative structure, there must be an appropriate structure for each residency program, and that's at the level of the programs now. So you need a program director, and you need a program training committee within the department, okay? And that's has the same issues that we discussed about the major training committee. Now, the program director is, to me, is the most important factor in the training, to be honest. And I'm sure my colleague going to be also talking about it next. Because without a good, enthusiastic program director committed, you won't get any program happening. And I sit a lot with program directors within committees or individually, trying to make sure that they are still alive, because some of them, they work hard for a year or two, then after that they give it to the chief resident, so he will do his tasks, do the call schedule, because this is the most important, because residents, they fight on these calls, but the other milestones that he has to make sure that they get it are forgotten. Okay? It only erupts when the Saudi Commission fails 50% of your trainees. Then you say, oh, why are they not attaining their goals? Then you start digging, then you will find that the program director wasn't doing his job. The other thing is the residency program committee, and I have to talk here about the interaction between the chairman and the program director. That's always the issue, because you really have to make sure that the chairman doesn't look at those residents and fellows as his, human resources backup. No. I was faced by a program director and a chairman last week saying, we did not have a lot of applicants for our fellowship this year. Would you please give us few residents through the program here or then? I said, no, those people are following their curricula. They are not going to come. Then they say, okay, why didn't you give us 2 international fellows in order to help us with the service? I said, no, our department is not the way to go. You go to the MCA, which is the Medical Clinical Affairs, and they will give you that. So you really have to differentiate the training from service. Again, the PD, the committee, and the subcommittee plan, they organize and supervise the programs. Now, the role of the department is very important. There has to be a commitment at the level of the department, and also the academic affairs. Academic affairs has to be really in strong contact with the department and with the programs. If they will just give it to the program director and leave him alone there, he could sink and drown, and nobody will know anything about it. But if you keep asking for data, asking for some certain KPIs, you will make sure that everybody's alive in there. Last year, we have came up with a project in order to keep some of that teaching alive at the level of the faculty, consultants, not program directors. And we've put together a requirement from every consultant to do 4 didactic sessions and 4 bedside teaching a year. That's nothing if you really compare it to 1 year. To date, we only gathered some data, not everybody, from 9 programs. 23 programs, only 9 responded to us. We meet with our program directors almost every month, and we ask them, and they have a lot of difficulty to potentiate it. Now, those sessions, we left it for them to define, because a surgical program is different than a medical program in the nature of what does bedside teaching mean, what does didactic session mean. Still, we haven't gotten much information, but that's the role of academic affairs, that they have really to make sure that they are on top of the training. Again, they handle the appeal process, the career counseling, the stress management, periodic internal review. That's very important, and you know, residents' opinion, open confidentiality, educational objectives is very important. You really have to record it, and you have to make it accurate, ready for whoever is going to be following on it. Resident safety, as we mentioned it, at the level of the institution is the same as the program. And site coordinators, that's very important. If you are training somewhere else, and usually the program directors on that program will be the site coordinators, research coordinators. Now, we have adopted something new in our hospital to promote research, where we put or encouraged department to develop research committees in each department, and headed by someone in that department who's interested in research, and he will be the person to promote it, and residents will go to it, to him or her, in order to be able to perform research. Our attempt to join them to our research center wasn't really very rewarding, except when we started funneling them to the data clinics. Again, the research funding, the publications, the involvement of residents, and the innovation. It's critical in some centers who lack some standards. This is very important, that you really have to innovate, and how can you patch your institution regarding the standards. And I talked to Ayman and Sami about, and Abu Umar, about the standards. Sometimes you may not find it in every hospital. You really have to give some room for innovation. These are good standards, but if we are gonna just stick to them, we know that more than 50% of the Ministry of Health institutions, they lack them. And Ministry of Health covers more than 85% of our clinical healthcare in the country. If we are going to stick to the standards, then we're not going to be able to create those 4,000 or 6,000 inshallah in the future. But that has to be really looked at carefully. Of course, we don't want to open these hospitals without good trainers or good programs, but again, we shouldn't be really just focusing on the standard itself. Am I okay with time, by the way? I'm taking my time this time, huh? 5 minutes, okay, time. So the goals and objectives are very important. The goals of the program and the objective for the residents. I know that in the last 2-3 years, the curricula of each program was reviewed and rewritten, and there are now tasks. I remember talking in a committee about it, and a wise person said, we want it to be like a transcript from a university. Like a chest tube has been inserted by the resident, so he will tick it. I don't like it myself. I'm a surgeon. I don't think surgeons or whoever should be looked at, but it is right. You really have to make sure that these people have met their objectives. Okay. So we have for each program a manual, and each program have all his tasks, and it has to be clear for trainees from day one. Specific objectives like knowledge, skills, attitudes. How diligent are we? Program directors may not be able to do everything, but they can delegate it to others. Like chief residents can supervise the other residents, make sure that they attain their objectives. Shared among trainees and trainers. As a consultant, when I train a resident, I have to know what am I supposed to teach him. He's not there just to see my patient and say hi to me in the morning and we keep going. No, I have to know what really he needs, and I have to deliver it. And if I don't deliver it, then I have to be reviewed by someone either in my department, program director, or by the academic affairs. Now the B3, which is the structure and organization, the rotations, the mandatory and electives to fulfill education requirements. Usually these are governed by the local committees and the Saudi Commission, and program directors are the people who are like doing it. Now, service versus training, this is again something that you have really to watch in your institutions in order to make sure that these people are getting training. We have put one of our programs on probation. By the way, the commission doesn't know that. We found that the residents and fellows actually are not abused, but they are used to cover surface. So the resident now is assigned in something, and suddenly he will get a call and say, go cover in the clinic. When we knew that, we made an official investigation, and we stopped like we said, you are on probation for 6 months. If you don't correct it, we're going to report it to the Saudi Commission, and we will suspend the program. And then the chairman started watching his way there. Okay, there has to be equality among residents, and of course, and role for his side, and the collaboration with other programs. Resources. This is one of the most common cited issues with whether it's human resources or non-human resources. At King Faisal, we never had this problem, but I sense it when I go on outreach in some hospitals. They really don't have the basics. Sometimes they don't have even a CT scan. They don't have a good lab testing. They have to send it somewhere else. In those situations, we really have to sit and think, is this something that we can, revamp by sitting and doing, collaborating with other, or we can declare that this institution lacks it and they have to do it. Patients, again, the number, the variety, the specimen, the gender, we have to make sure that there is no such a called male hospital. Then they will be able just to deal with certain patients and then the others. Resources, again, is an issue, but I think, as I said, every program through their committees, they have really to decide on what is the minimal. So the hospitals will be able to meet them. Saying we need everything will get you nothing. Clinical, academic, and scholarly content. These are basically the CAN-MED. I think all our program directors are trained now on the CAN-MED ones. Medical expert still is the most important one, because we still think that the training should produce a competent physician. But the other ones are important because this physician who's going to be finishing now and working, he's the one to develop the others. If he doesn't have the other skills, he will not be able to deliver the rest, even his skills, his own skills. Health advocates, this is another issue. I tried even to create an advocacy clinics, I call them. So residents will be practicing for an hour or two about the common, population-based studies, diseases and stuff, but we still don't have them. Scholar, research is the most important, of course. Professionalism is very important, and I think role models are very important. Assessment of residents' performance. I think the Saudi Commission lately have invested a lot, and we have now, I think, the I-45. We really have to encourage our people to use them. The TRS was a major failure because it was very complex. We tried to start it years ago through the commission, and it wasn't really nobody really adopted from the piloting the programs. But the I-45, I think, is I'm hearing good things about it from our program directors, and it should be really adopted. Assessment of resident performance at the level, I think the local committees are doing a very good job. The exam committees are doing a good job. The assessment unit in the Saudi Commission is doing an excellent job. They say regular documented feedback face-to-face. I always think about our residents sitting in front of an appraiser. Sometimes, there is a lot of intimidation by the appraiser or the program director. So you really have to make sure that this is a two-way dialogue rather than a one-way one. And we try at King Faisal to make it really more objective rather than a one-to-one. So we have an open door policy, and we potentiate residents and empower them to come forward and complain if there is a problem. Now, how to improve? This is the last few aspects. I think it's many aspects. Trainee empowerment, they have to be aware of their objectives and the goals of their program. They have to have an open door policy for program director, for chairman, for academic affairs. They have to be aware of the rules and regulations. They have to they have to be part of committees that are really able to give them the opportunity to share with you their issues regarding training, whether it is the large committee or the big committee in the hospital or even subcommittees. We have a quality trainee committee at King Faisal. We really have benefited a lot from it. I claim it's much better even than the medical one at the level of the CEO, because most of the quality ones are done at the level of the trainees, and they're really doing an excellent job. I chair it, but I never attended it. I let the coordinator lead it, and I'm in the back. If they need me, I go there and help them. And it's really working beautifully. Empower the chief resident role and the residency retreats are very important. If you can get the residents together and ask them to meet and talk about their issues and give you some recommendations, I think that's very, very important. Empower the faculty. As I said before, you really have to develop them, you have to give them incentives, you have to share decision making with them. If you ask them what they think about how should this standard be delivered in the hospital, they will be with you when you go there in order to implement it. But if you leave them in the shed, when you suggest you just do it, you may not have that kind of help. And again, faculty retreats can also be a source of information. Program director, program committee empowerment, I won't go over this. We talked about it enough. You really have to empower them. Program director really have to be in charge of the training. Even academic affairs should not really interfere unless there is an issue. Okay? Now, but program directors have to understand that they are, they are also accountable and responsible to academic affairs the way that they are responsible and accountable to the Saudi Commission. Because in the past, they thought that they are in control through the local committees. I think if the academic affairs are not doing their job, then this is fine. But if the academic affair is really on top of everything, the program director has to be, accountable to them. Educational committee empowerment, as I said, this is very important. They have to be a transparent conduct of its activities and empower the position as a core training in the institution. Academic affairs, they have to be also empowered by the CEO or whoever is doing the administrative role. There has to be availability from data from the Saudi Commission, so we will be able to analyze it and help. And involvement in the regulations and the policies. We have to conduct the same manner that's done every 3 or 4 years in order to be in a state of readiness, and more important, to make sure that these standards are applied in our institutions. And we have to encourage innovation, as I said earlier. Others share success stories among programs, continuous development of processes. That's very important. You really have to have processes to do your things in the hospital. If you are doing it individually, that's not going to work. Goal-specific task forces, they help you to sort out a few things. Involvement of and responsiveness to other institutional sectors and individuals. Finally, I think it's the commitment in the institution what really makes the difference. If your administration and your academic affair and your medical departments and your other departments are committed to training, then your residents will be safe and they will feel welcomed anywhere they go in your institution. If that's not the case, you're not going to be able to train them. Thank you.
Thank you so much, Professor Saud, for this enriching presentation, and the floor now is open for questions. Microphones, please.
Assalamu alaikum. Thank you very much, Doctor, for the very nice presentation. Dr. Amal Mana Obigaini, Program Director from National Guard, Dmam. Now, I was just questioning about our program is very, it's just in a junior level this year. We were just asking, I was just wondering, program directors, are they having any it's like before starting the program, do they have any special training? Do you expect them to attend courses for such issues to start efficiently? And because we faced some difficulties, and I was surprised. Our program directors, the old generations.
How they do it. Yeah. I mean, like, it depends on the level of activities in your hospital. If you are in a hospital that has only 2 or 3 or 4 residents start, and you don't have a lot of administrative work and it's not a busy situation, most of the program directors, they get most of their directives from the local committees at the level of the Saudi Commission. They learn from being in that committee. Okay, and it usually starts reactive. You react to whatever comes. Let's do this, let's do that, and you will go back to your hospital and you will do it. Now, if you are in a hospital where you have a long heritage and that, in our situation, we never really appoint a program directors right away, or we avoid it. We usually have a deputy for the program director. Usually I push on them for at least 6 months, they shadow them. Okay, so if someone now come to me as a program director and say, I'm done with it and I can't deliver anymore, I said it's fine, but you have to commit another 6 months, and we have to find someone who's going to be your successor. So that person will shadow this program director now, who knows now everything, and then after that he will take the role. Exactly, but here is the deal. In an institution where they have a history, there will be, you're talking about other committees that governs the training, not that person, okay? But I'm not saying that this is not going to happen. It could happen. A systematic error could continue in an institution for years before someone will wake up. But it's hard to believe that they will continue something like that if they are interacting with the Saudi Commission and interacting with the training committee and interacting with the subcommittees and interacting with the department. I'm coming to the point of development. We have some training, like the CanMed. I think every program director in the country has been through the CanMed training. And I think in the last year or so, we slowed down for certain reasons. But our program directors, usually, when they join, we have surveyors and we have CanMed instructors, and they give them that skill. And we are, by the way, I think the committee now, the commission is starting now a training development. And in King Faisal, we are doing our own faculty development for our program directors. Every year we have 2 or 3 skills programs or something to train them.
The Saudi Council is not.
So the council, they're going to start. They started, I think, with piloting.
I'm just saying that we should be starting before the program director starts his own work.
I agree with you totally, to make them ready for this role.
Just a 30-second comment. We're developing an online module. Do you know there's like 700 program directors? It's very hard to do it didactically on the field. So we're just finalizing a 3-hour new program director online module that's very interactive, at least covers the basics. So nobody will say I did not know, or it directs you to resources. ترى في manuals هنا وفيها أسئلة وفيها resources وclips, so it's been very well developed. يعني فيها animation وفيها live وفيها مقطع من محاضرات الدكتور سعود وسرقنا من غير copyright يعني. فإن شاء الله hopefully that will.
Thank you very much, Dr. Saud. Let me start by saying it's really nice to see you after so many years. I think the last time we met was in IWK 2003 in Halifax.
My goodness.
Dr. Amjad Badr, Program Director of Anesthesia in Johns Hopkins Aramco. My question is that it seems that our residents up until today, they are not really getting the essence of the CanMed's competencies that a lot of the programs had adopted. They keep thinking proficiency is all about the knowledge and passing the exams, etc. What I have in mind, I mean, we all know that the practice of medicine is not only about performing a surgery or treating a medical condition. A great deal of it is has to do with empathy and compassion to our patients. What work have we done so far in that area to increase the knowledge and understanding of our residents? Having asked this question, it brings another thought to my mind. There are certain programs in Canada who had established what they call a 360-degree evaluation. Yeah. In other words, the residents are not being evaluated only for their clinical skills or knowledge, but rather even their evaluations are passed over to other non-doctors, professionals, to comment about their attitude, about their relationship with the patients, about communication skills, etc. For example, a resident would have to be evaluated by the clinical clerk, by the technologist, by whoever happens to be at the workplace, in addition to his mentor, the physician. I think this is important because at the end of the day, we don't want just to create medical experts. We want professionals at their at their fields. So what are the things that we have done so far regarding that area? Thank you very much.
I think this is a very sensitive question. When I said that this presentation is evolving, it's still evolving, by the way. And when I was listening to my colleagues in Riyadh, I have put some comments here, and I really, since my colleague here from Halifax, I have to give him something special. So I have to say something. I was actually talking to Dr. West just a few minutes ago, and I mentioned to him that although we have the standards, we really, or I understand myself, that these standards came from different environments. Like when we bring it from the ACGME or from the Royal College of Canada, we're talking about people who already passed almost 100 years in training, and when they maxed at the clinical, they became knowledgeable. They started asking themselves, what's next? What do we need to innovate in our training? Then they came up with these, whether you go to the CAN-MID ones or the values added in the ACGME. So how can we, in this country now, 25 years old training, well-structured training, how should we react to that? The other thing that I want to add, which is another important paradigm that you have to understand when you interact with your program directors or with your residents or fellows. Our education system in Saudi Arabia has been spoon feeding, and it's still, by the way. My son now in the intermediate school, I'm having difficulties to push him beyond the books, despite the fact in his school now they have pushed him away from the books. They're trying to get them into this thinker, analytical, all these nice words. He's not having difficulties to understand them, but he wants just to stick to knowledge, because when they are assessing him, they only give him an exam. So he does it, 100, and he's passing, so he says, okay, this is what you want, I got it for you. But when we talk about training now and how to add these values, I think it's very important to understand the issues of our trainees. Now, I have written this when I was listening to Dr. Aribi and Dr. West in Riyadh. I said we really have to be sensitive to our trainees' characteristics. Gender, for instance. I'm a consultant here. The way I approach a female resident and a male resident, you ask me by default to say, oh, they're the same. Actually, they're not the same, and they shouldn't be the same. Because in our culture, males are different than females. Okay? There are certain things. They are not different in a way that one of them is better. No. But each one of them has a way to funnel the information or the standard, if you wanna put it. So this has to be taken care of by even program directors. If a male program director now is in the OB-GYN program, and we know that most of our OB-GYN residents, you can correct me on this, at least in the last few years, they were females, and he's a male. How will he gonna react to the needs of his own residents? Are they gonna be open with him? So you really have to be sensitive to that, and we have to acknowledge it. Yesterday we were appointing a fetal coordinator in our clinic. And we have a few applicants, but one of them was a male. Like, can you imagine a coordinator in a fetal clinic with a pregnant lady stressed by an abnormal fetus, okay, and taken care of by a male in this culture? And I think it's the same, okay? We have also to be sensitive to the trainers, our trainers too. Like the consultants, what are their background? Where are they coming from? What are their values? Institutional factors too, we talked about it. And the culture and the societal factors. They have to be taken into account. If we don't have the time to think about them, at least, not to write them down, and funnel the information in that path, then we're not going to be able to attain any of these goals. We really have to stay focused as well, because the output, as I said, is what? good, safe doctors who will sustain and develop postgraduate programs. So going back to your question, my friend, the issue here of the CAN-MED, we learn them and we try to do them as much as we can, and it is up to the program director / academic affairs. For us, we brought all of them and we put goals for each one of them, so our program directors are always trying to deliver that. The one that I struggle with, to be honest, is the leadership. We try to get the residents involved in leadership roles, but you have like 550 residents in the hospital. You can't put them on top of things to lead, you know? But you try to infuse in them that they are leading something. They're leading care, they're leading teaching, they teach students, they teach things. But the factors of those residents also dictate sometimes what can we deliver to them. But it's a journey. You start, but if you really focus on them, you will reach somewhere and you will be able to attain them.
Thank you so much, Professor Saud. I think if we continue, we'll never stop.
I told you, this is,
very
yeah,
rich subject.
yeah, it
A
is.
small comment just before we conclude here.
أعزائنا الحضور، نشكر لكم حضوركم ونفيدكم بأن الآن فاصل لأداء صلاة الظهر وتناول وجبة الغداء. حيث أن الجلسات سوف تستأنف إن شاء الله الساعة 1 ظهرا.